Good afternoon. I'm Dr. Ashish Mananda here to present umbilical cord patch grafting in corneal perforation and desmetocele, a novel approach. If you are using it, then I cannot use it from here. I have no financial interest. Globally, 1 million persons are blind due to corneal opacity, which is fourth most common cause. And for this corneal blindness, we generally do keratoplasty. For keratoplasty, we need donor cornea, but in COVID pandemic situation, 50% decrease in corneal blindness has been noted. So for that, we need an alternative structure for these dire situations. Amniotic membrane has previously been used for these cases, but now umbilical cord is in limelight because this has more number of collagen and it has mesenchymal cells, which is totipotent in nature, which can be isolated from the subamnion. For this, we have objective of a study. The aim for the study is to evaluate the clinical outcome of the umbilical cord patch grafting for deep corneal ulcer with perforation and desmetocele. For that, we have done one prospective interventional non-randomized single-arm single-center study with 48 subjects. Each subject has been participated and followed up for 6 months, and the entire study has been done for the 1.5 years with 3 phases of the study. From 18 to 65 years old patients has been included in this study with both gender, with corneal perforation due to infection and non-infection of size of 3.5 to 4.5 millimeter with no prior history of keratoplasty. As an outcome, we have taken graft-host integration, corneal thickness over the time period, reepithelialization time, improvement in visual acuity and anterior chamber depth. As an intervention purpose, first we have measured the defect, and then the twice of the measurement of the defect has been cut out from the dried umbilical cord. Then it is fashioned as a circular patch, and it is placed over the cornea and soaked with balanced salt solution, and then it is attached with cornea with 8-10-0 monofilament nylon. Then the anterior chamber is formed with air and BCL has been placed. In this case, you can see there is a desmetocele with vascularization and inflammation. After 6 months of post-op, there is no vascularization, inflammation has been reduced, and there is a good graft-host integration you can see. In this case, a patient has come with corneal perforation due to trauma, who has undergone the umbilical cord patch grafting and also cataract, and the post-cataract vision was 624, unaided. Here, the gradual photograph, you can see there is fluorescent slit lamp examination showing gradual reepithelialization, which is also evident in ASOCT. In this gradual picture, you can see the post-op 3 months, there is a clear demarcation line between graft and host, whereas post-op 6 months, there is no clear demarcation line. In this histopathology, you can see there is epithelial hyperplasia, which is from the umbilical cord. There is granulation tissue which is being formed due to the graft-host integration, the compact collagen of umbilical cord, and below there is a newly formed collagen fiber from the in the cornea. The mean reepithelialization time is 19 days, whereas the mean graft-host integration is 84 days. The mean corneal thickness was 412 micron after 6 months, whereas 206 micron is the mean umbilical cord thickness after 3 months. There is no visual improvement or anterior chamber depth change in the time course. But there is one patient who has developed the hypopyon, 2 patients has developed vascularization, and 1 patient has developed corneal thinning. In the conclusion, we can say that umbilical cord patch grafting can give a good tectonic support. It can be used in corneal perforation and desmetocele in dire emergency situation. It helps reducing the inflammation, and there is a good graft-host integration. It also maintains the anatomy of the anterior chamber. As a limitation, I can say the number of the sample size is less and the follow-up period is less. So we can see for the more longer follow-up period to see the late complications and longer post-operative outcome. These are my references. Thank you.
Nice presentation, Dr. Ashish.
Thank you, sir.
I appreciate you. Is it the whole thickness of the umbilical cord did you use?
No, sir.
Refine?
No, sir. There is a procedure for processing this umbilical cord. We don't process it in our institute. Company does it. So I have I have asked them the procedure, and the procedure is first they cut out the umbilical cord, and the Wharton jelly and the umbilical veins and cords has been removed. Then they only take the subamnion and the amniotic membrane of the umbilical cord, which is approximately 250 micron when it is wet. But then what they do, they just only dry heat it. They do not give any other preservatives or anything. So that reduces the thickness at around 150 to 100 micron. So it can be preserved for longer period, and they just do it ETO and they just sell it like that. So while when we use it, we just get the subamnion part and the amniotic membrane part. So that gives the mesenchyma and also the collagen part of
All
the.
right. The second question is, how do you preserve?
We preserve it in a normal temperature. We don't need to have any fancy like storage procedure. They just ETO the umbilical cord, they double pack it and they send it to us, and then we use it. It can be stored in normal temperature.
And for how long you can store like this after ETU?
The expiry date is 6 months. The company, I have no financial interest. The company, those who sells that, the company name is LifeCell. They give it as AmnioPlus Thick. They have 3 products, one AmnioPlus 1, 2 and Thick. 1 is only amnion, 2 is amnion plus chorion, and AmnioPlus Thick is amniotic membrane and umbilical cord. So this is how they sell it to us, and this is it.
Did you follow up all the patients for 6 months or more than that or less?
6 months is the least.
Least. So
This study,
during the course of follow-up, did you find any change in the thickness? As you said, the umbilical cord was completely integrated into the corneal tissue in how many months? How many weeks?
3 months.
3 months. So is there any changes, any deposition of the collagen under the umbilical cord sheet? Did you find anything change in the thickness of the whole corneal stroma?
Yes, ma'am. I can. This is the picture I would love to show you. Here in this picture, you can see this triangle. There is a compact collagen which is from the umbilical cord, and beneath there is loose collagen tissues which are newly formed, and these are recently I have done CD34 immunohistochemistry. I couldn't present it over here because this is on the process. So they have shown in that picture that there are different collagen. One is the umbilical cord, which is the above part, and down there is the newly formed collagen, which is collagen 4 of the cornea.
So how it is advantageous over the Tenon's page, because it is readily available? Why should we go for amniotic membrane if Tenon's is readily available there?
Sir, the cases where I have performed this amniotic membrane umbilical cord patch graft, the cases are already, the cases who have come to us are already inflamed in nature. So I thought not to put tenons from those inflamed eye where I have already have an alternate tissue where I can just put it over there and not to harm the other eye or that eye, where if the person has come with a trauma, then that eye is already inflamed, and that person is partially blind in that eye. So if I take tenons from other eye, that eye need to be patched for 1 or 2 days, maybe that eye also get inflamed. So why to risk other eye or that eye even when it is an inflamed situation? So for that, if I can use in another structure which is similar to this and which won't jeopardize the other eye or that eye situation, so why not try this?
Thank you.
So, thank you so much, Dr. Ashish. We move on to next presentation by Dr. Shadma on surgical management of perforated PUK in COVID-19 pandemic.
Good afternoon, everyone. I'm Dr. Shadma from AIOCMTC1 and will present case series on surgical management of progressive PUK in COVID-19 pandemic. This is not moving. Please reset. Good afternoon, everyone. I will be presenting case series on surgical management of progressive PUK in COVID-19 pandemic. There is no financial interest, there is no conflict of interest. PUK is a form of unilateral crescent-shaped inflammation which involves the juxtalimbal cornea and is characterized by sectorial thinning of the affected area. It is always associated with an overlying epithelial defect and progressive loss of corneal stroma. Progressive thinning may lead to corneal perforation. The surgical alternatives in the management of perforated PUK in absence of donor tissue include Steenan's patch, tissue adhesives and amniotic membrane graft. We are reporting 2 cases of perforated PUK and 1 case of impending perforation of PUK where multilayered AMG has been used as a surgical alternative. The purpose is to report the role of AMG in restoring the ocular integrity of perforated PUKs in COVID-19 pandemic. This is retrospective case series of 3 patients. Our first case was a 17-year-old male who came with complaint of pain, redness and watering in left eye with incidental history of fingernail injury. The systemic workup revealed patient was HLA-B27 positive. Right eye ocular examination was within normal limit. Left eye vision was 1/60 with perforated cornea ulcer with iris prolapse from 6 to 12 o'clock hours, 3 mm wide, progressive with vascularization present. AC was flat and fundus could not be visualized. We planned for AMG with glue. This is post-operative picture showing AMG is well placed with normal IOP and well formed AC. This is post-operative ASOCT showing well incorporated AMG. This is follow-up picture of the patient after 1 month, which shows the AMG has restored the ocular integrity of the patient, of the cornea with improvement in vision to 6/36 with normal IOP and well formed AC. Our second case was 35-year-old male who came in complaint of pain in left eye. He was diagnosed case of HLA-B27 and was on oral steroids. The best corrected visual acuity was 6/18 and there was progressive thinning noted over 3 to 4 o'clock hours, encroaching 1 mm of the cornea. ASOCT done on the day of presentation. The corneal thickness was about 350 microns, but on day 3 the lesion progressed and the corneal thickness was around 251 microns. So we proceeded with multi-layered AMG with glue. This is surgery which I assisted where we placed multi-layered AMG and secured with sutures and glue was placed with BCL. This is post-operative ASOCT showing well incorporated AMG. After 1 month of follow-up, this image shows the well incorporation of AMG in the patient. Vision improved to 6/12 with well formed AC and normal intraocular pressure. Our third case was 56-year-old male who came with complaint of diminution of vision in left eye. He was a known case of rheumatoid arthritis and was on oral steroids. His vision was hand movement. There was perforated cornea ulcer noted with iris prolapse from 12 to 4 o'clock hours and 5 mm wide. AC was shallow. We performed multi-layered AMG with glue. This is post-operative image showing well incorporated AMG, normal intraocular pressure and well formed AC. And the vision improved to 6/36. The investigations we did, a conjunctival swab culture was done in all 3 patients which came out to be negative. Conjunctival biopsy revealed a few chronic inflammatory cells. Other blood investigations were within normal limit. We started the patient on oral corticosteroids, topical steroids along with topical cyclosporin. Amniotic membrane grafts are used as substrate for the growth of epithelial cells and for tectonic support in all cases of small perforation and thinning of cornea. It expresses anti-inflammatory, antimicrobial and anti-fibrotic factors. Various studies have documented the role of multi-layered AMG in maintaining ocular integrity. The various clinical implications of AMG are small perforations and thinning, PEDs, chemical injuries, bullous keratopathy after OSS and excision. So to conclude, during pandemic there was scarcity of donor cornea and AMG served as a good surgical alternative. It is a safer method to restore ocular integrity in perforated PUK and impending perforations in emergency setting. Thank you.
It's a nice one, doctor. And I do agree with you. Amniotic membranes, they are good substitute when we lack cornea, and moreover they also have antifibroblastic and they are promoter of epithelialization and anti-inflammatory too. So what type of AMG did you use? Are they fresh membranes or preserved ones?
The preserved ones, sir.
Preserved ones, okay. Okay, I don't have anything.
Please, next presenter, please come and get ready with presentation.
So why did you use cyanoacrylate glue? Because it causes a lot of inflammation. Since the condition is inflammatory, so can you try other options like fibrin glue and all?
It gives a better tensile strength compared to fibrin glue. It has bacteriostatic effect as well, cyanoacrylate glue.
And when to remove glue? When did you remove the glue, or it fall off spontaneously?
So it fell off spontaneously.
Dr. Neha, please come. Dr. Neha Kiran, she is going to present on a study of incidence of VKC-induced astigmatism. So next one is ocular anaphylaxis by Dr. Vidyabhushan Kumar.
Good afternoon, ma'am and sir. I am going to present ocular anaphylaxis management and its a clinical outcome after corneal bee sting. There is no financial interest. First case is a 4-year-old female child referred to RIO with complaint of swelling, increased lacrimation, pain, and not able to open her left eye for past 5 days. This episode had occurred after swarm of bee attack her all over the body, and as told by her parents. Patient initially visited to the local ophthalmologist where implicate treatment with oral NSAID and antihistaminic drugs were given and referred for the further management. On examination, gross examination, we found out there is a mild periorbital edema, which child was unable to open her left eye. After gentle lid opening and torchlight examination, upper and lower eyelid very edematous, diffuse lacrimation, conjunctival ecchymosis, and corneal edema was present in her left eye. Slit lamp biomicroscopy evaluation revealed foreign body, maybe bee stinger embedded into the deep stroma of the cornea, temporary at 3 o'clock position, 2 millimeter from the limbus in her left eye. There was infiltration around the bee sting and generalized corneal edema. This may be due to toxic immunogenic response. After anterior chamber detail could not appreciated, anterior chamber depth seems to be normal, pupil pharmacologically dilated, and lens was clear. USG B scan was done, but B shows within normal limit, but anterior segment OCT saw corneal edema, which is with diffuse bulle was present. Patient was taken under general anesthesia for examination and foreign body removal. Intraoperative, we noted 2 foreign body was there. One was present in the cornea and one is stuck in the anterior chamber with iris. Both bee sting was removed, and because of this anaphylaxis, iris become heterochromadia iris-like condition, and cornea was fully edematous due to anaphylaxis. So both foreign body was removed and sent for the HPE, and we saw the bee stinger. Post-op oral steroid 1 mg per kg body weight was started, antihistaminic was continued, topical antibiotic, lubricating, and cycloplegic eye drops was continued. 1 week later, stomal edema resolved completely, although small opacity in the site of the bee sting was remained. Child was able to open her eye comparatively, but vision improved only up to 636. Anterior chamber was quiet. Patient was registered for the optical PK. Case 2, 46-year-old male referred to the dimness of vision in his left eye with history of honeybee attack, and he's almost 3 months back. After bee sting was removed and medical management was done, all symptoms were subsided, but vision didn't improve significantly, so patient was referred for further management. And on examination we found out vision was 660 with slit lamp evaluation, so corneal opacity, superior neovascularization, and lens was cataractus. Other finding in the anterior chamber was within normal limit. Patient planned for the optical PK, and after that phacoemulsification and PCI also. This is the pre-op picture, and after optical PK, post-op picture is there, sir. So patient get vision, good quality of vision. So my discussion is corneal bee sting have been rarely described in the literature that can lead to the potentially devastating complication like ocular anaphylaxis, including keratitis, corneal opacity, bullous keratopathy, uveitis, iris atrophy, secondary glaucoma, cataract, optic neuritis, and even phthisis bulbi. Treatment is usually limited to minimizing the toxic immunologic response. However, due to the rarity of the injury, there is no established clinical guideline and management. Yearly surgical intervention, which include removal of the bee sting and high dose of steroid, along with the topical and antibiotic steroid and cycloplegic, may be the main stay of the treatment. Prompt and yearly intervention with removal of bee sting, oral steroid is must. Almost all patients need keratoplasty surgery due to severe inflammation and further corneal opacity. Thank you.
Your presentation as well. Okay. Thanks for bringing up this wonderful thing in this meeting. I do agree. Insect hairs can produce dermal and ocular surface inflammations.
Yes, sir.
But mostly, they settle with steroids.
Yes.
Okay. And your statement of they invariably need keratoplasty is, I think, it is
my experience, we find out, sir, they are
maybe in your case series it required,
yes, sir.
but mostly ophthalmia nodosum
Yes, sir.
and insect hairs, they don't need keratoplasty, and generally they cause encapsulation around the setae or the sting or the hair,
Yes, sir.
and they settle, and they can also migrate internally. Some of the species can migrate. And on another observation, maybe the term anaphylaxis
Yes, sir.
referred to a generalized condition
Yes, sir.
of type 1 hypersensitivity reaction. Maybe it's a misnomer in your case.
Yes, sir.
I'm not challenging your terminology,
yes, sir.
but maybe a misnomer.
I do agree with you, sir. But my case was ocular anaphylaxis, means involvement of eye, my topic was there, sir.
It's a hypersensitivity,
Yes,
no
sir.
doubt. But is that type 1 IgE mediated? We don't know.
Oh, yes, sir.
Maybe a misnomer.
Thank you, sir.
How was the endothelium there?
Corneal edema was there, sir. Stoma edema was there, significant.
Is it temporary or permanent? Permanent edema was there?
No, after removal and steroid, edema was subsided, and ASOT we saw that there was a reduce of the edema, but opacity was there, sir.
Okay, so what was the diameter of opacity? Because we believe that it's merely a small sting, so opacity should be very small, but in your case it is quite big. So
Yes,
is
sir.
there any melting of stroma over there?
It
Why
was
the
not.
opacity is so big? Because I think
Yes, sir. This picture is like first patient had very full means limbal to limbal edema was there in this picture, with even though only one foreign body was here, but due to this reaction, full corneal edema was there, and epithelium loss was there, sir. Thank you, sir.
So may I call upon next presenter, a case of perforated corneal ulcer secondary to metaherpetic keratitis by Dr. Niranjan. Yeah, it's a trend of ocular chemical injuries. You are not going to present this one? Okay. You can present your next paper, 1686, right?
Good afternoon. I'll be presenting a trend of ocular chemical injuries in a tertiary care institute. Chemical injury to the eye accounts for a significant portion of ocular trauma. Ocular chemical injuries constitute around 7.7 to 18% of all ocular traumas. Chemical exposure to the eye results in trauma ranging from mild irritation to severe damage to the ocular surface and anterior segment, which can ultimately lead to permanent visual loss. The sequels of chemical injury may have significant detrimental visual and psychological effects of the affected individual. So, proper management in the acute setting as well as follow-up is crucial in limiting adverse effects of ocular tissue damage secondary to chemical injury. The aim of this study was to review the risk factors, clinical profile and management of chemical eye injuries in a tertiary care hospital. A retrospective study of patients who presented with ocular chemical injuries was done in a tertiary care hospital. Case records of patients who presented with injuries to the institute were reviewed over a 1-year period, and the data was compiled and evaluation done. The results of the study included 77 eyes of 58 patients who presented with ocular chemical injuries. Out of the 58 patients, 22% were female patients and 77% male. The average age of the patients was from 32 plus or minus 14 years of age, ranging from 5 to 62 years of age. This is the age distribution group. Major age was between 21 to 40 years of age group. Among the 58 patients, 18 patients, that is around 33%, suffered bilateral injuries, and the bilateral injuries were more in eyesight injuries compared to alkali injuries. Alkalis contributed for injuries in around 31% patients and acids in around 68% patients, and these were the different chemicals involved in the injuries. This shows a comparative analysis between different grades of the chemical injury and the visual impact representation. The visual impact was better in lower grades of injury compared to the higher grades of injury in both acid and alkali. Out of 58 patients, 53 patients sustained accidental injury, while 5 patients was non-accidental, and 30 patients suffered injuries in workplace, while rest suffered injuries at their home. All the eyes with severe grade chemical injuries were treated with amniotic membrane transplantation in our hospital. In the present study, the mean age of presentation was 32 plus or minus 14 years, emphasizing the vulnerability of young adults. Studies by Kuckelhorn et al. And Singh P et al. Also correlate with this finding. As reported by many other authors, as well as in this study, males outnumbered females in the frequency of chemical injuries. Most common causative agent of chemical injury was hydrochloric acid among acids and calcium carbonate among alkalis in our study. And most of the cases presented with unilateral involvement, bilateral involvement was less common in our study. The prevalence of unilateral involvement was more severe in acid injury compared to alkalis. Most of the cases in the present study had lower grade of ocular injury, as they were given prompt first aid on reaching to the hospital, which decreased the ongoing process of ocular damage by removing the insulting chemical agent. So the conclusion, early presentation with good presenting visual acuity carries a good structural and visual prognosis and lesser complications. Despite advances in medical and surgical treatment modalities, the consequences of severe chemical burns can have profound consequences to the patients. For this reason, for patients presenting with chemical injuries, whether they occur in the workplace or at home, early recognition and prompt treatment by the treating physician remain the standards for maximal preservation of ocular tissue.
Thank you for your presentation. It's a good epidemiology research question. It's a retrospective, right? Retrospective analysis.
Yes,
I wonder, why did you not consider the time of injury to the time of first intervention?
Yes.
Maybe in future research,
Yes, sir.
I think that plays a vital role.
Yes, sir.
And one more highlight is 9% are non-accidental.
Yes, sir.
Probably inducing homicide type of things.
Yes, sir.
I don't know. That is quite huge also.
Yes, sir.
Yeah. The time of onset to the time of first intervention, I think you can add in future researches.
Yes, sir. Thank you, sir.
Yeah, it's. I also agree with the fact that time of injury to time of presentation as well as time of intervention should be noted, and it's a good study. Just I want to know one thing, that there are many studies in the literature that have already documented these facts, that unilateral injury and young age group, they are more affected with these accidental traumas. Good that can be in benefit of public health?
That's ma'am the same thing, that is initial management is very important ma'am. All the injuries which had lower grade of injuries, since ours is a tertiary care institute, all the patients who presented with lower grade injuries, they actually had first aid treatment given in their, at least in the local hospitals or in the first primary treating physician. So that is an important factor. So I'll say primary treatment, at least proper eye wash is important in case of all the chemical injuries.
Okay, thank you.
You included pediatric population also, no?
Yes sir.
Because mostly in pediatric population, the injuries are alkali because of tuna packets.
Yes sir, the tuna packets.
So in your study it is.
Yes sir, our study most were young adults, but there was one case with 5-year-old also sir. Youngest was 5-year-old.
Thank you.
Thank you.
So we'll move on to next presentation by Dr. Nikita Chaudhary to compare topical cyclosporin versus prednisolone acetate for the management of stromal keratitis. Is she here? So next presentation would be microfiber neuropathy in cornea in post-COVID-19 cases complicated with ocular surface disease by Dr. Sarkar. Is he here? So next one is by Dr. Kanishk Singh, Dr. Rajesh on Harboyan syndrome. Okay, please come. He's here.
Shall I start? Respected judges, my dear colleagues and seniors, myself Dr. Rajesh Pattebahadur. I express my gratitude towards the AIOS for giving me the opportunity to present here. So, title for my case presentation is the Harboyan syndrome. It's a rare case report we find out. So, what we got? We got a 13-year male patient which was referred from the pediatric OPD with a complaint of the blurring of vision. There was nystagmus and the right eye esodiation was present. Child was born out of the LSCS with a full-term delivery. He had a low birth weight history, but there was no an ICU admission for the 5 days, but with the no history of oxygen supplementation or prior or the current treatment for the ROP was not documented. Earlier ophthalmic evaluation was done on the local aspect, but no documents were available with us when the patient presented to us. So this was the ophthalmic examination. The BCVA in the right eye was 1/60, in the left eye was 6/36. Both eye had a nystagmus and right eye was having esodiation. Rest lead conjunctiva and sclera were within physiological limit. In the cornea, we found out that patient had a bluish haze. Endothelial edema was evident on the slit lamp. Corneal diameters were within approximately normal limits. IOP was not able to record it, but digital IOP was normal. Rest, anterior chamber, iris, pupil lens were within the physiological limits. So, what we got was a male child with a corneal haze with suspected endothelial disease. But there was a twist. The parent gave history that child was having a problem of hearing. So we did the ENT evaluation. On the ENT evaluation, BERA was done and we found out that patient had a bilateral sensory neural deafness. The right was having more, the right ear was affected more than the left eye. So we did these are the clinical pictures suggestive of, this is the pointer again. The picture on the other side showing the right eye having the bluish haze. The stroma was thickened, CCT was thickened, which was evident on the slit lamp. Other one is, this is the right eye, which has a less corneal haze, which corresponds to the BCVA, which we saw on the first slide. Again, the same slide, both are having the bluish discoloration and the corneal thickness was enhanced. This is an ENT evaluation, BERA report, which is suggestive of right eye moderate to severe hearing abnormality and left eye moderate hearing loss. So we did the literature research for any disease of the dystrophy which was affecting the endothelium plus sensory neural deafness, which was like corneal degeneration since birth and late onset sensory neural defect. So we found out the conclusion to be an Herboyan syndrome. So we made a diagnosis for the Herboyan syndrome for that patient. Now what is Herboyan syndrome? It's in the 1971, Herboyan described it. It's a rare genetic disorder. It could be caused by SLC4A11 gene located on the 20 chromosome. Can be X-linked recessive or the dominant. And CHED, congenital hereditary endothelial dystrophy, and Herboyan syndrome has a many overlapping features where we see the bilateral congenital corneal endothelial dystrophy along with the bilateral progressive hearing loss. Generally, corneal involvement can occur by birth to the 16 years of the age, but most of the cases present within the first decade. Someone who has a abnormality in the hearing abnormality, generally the cases has a X-linked recessive presentation. In the ophthalmic features, generally patient presents with the bilateral clouding of the entire cornea. Within first year, central corneal thickness is increased. There is a epithelial and the stromal edema. Vision is severely hampered. That's why patient generally presents with a nystagmus. The histopathology of such cornea reveals the degeneration of the endothelial cells and the descemet membrane thickening. In the ENT aspect, we generally see the sensory neural hearing loss with the variable ages of the onset. Right and left eye may have a variable amount of the auditory loss, and it's a slowly progressive thing. It's not a stationary thing. So we came to the conclusion with the following DDs: CHD 1, 2, 3, 1, 2, Peters anomalies, scleral cornea, congenital glaucoma, Hurler syndrome. We can differentiate on the basis of that. What we did was we give the hypertonic saline artificial tear. We advise for the endothelial keratoplasty and genetic counseling since they were not available with us. Definitive treatment is a bilateral endothelial keratoplasty. For hearing loss, cochlear implant is the best thing. So take home message is awareness among the ophthalmologists and the ENT surgeon should be raised for the Herboyan syndrome to ensure the prompt treatment. Thank you.
Thank you. Nice presentation. Did you get genetic analysis done
no,
for this
no,
patient?
Due to the financial constraint, we were not able to do. That was supposed to be done, but we tried, but there was issue with the patient lost to the follow-up, and for the financial constraint also, they were not ready for that.
Thank you.
How did you intervene?
What we did, so actually, ideally we should have done endothelial keratoplasty, but since that was not available with our center, so we had to refer that patient.
But the stroma?
Stroma was hazy.
Was it localized to endothelial disease or a stromal?
No, sir. Stroma was also involved. If you allow me to show, I can show the pictures. Just a second. This was for the right eye. The stroma was severely hampered. So endothelial keratoplasty is documented in the literature, but depending upon the involvement where stroma or the anterior stroma is also involved, then we have to go for PK only. Endothelial keratoplasty may not help.
Most often congenital hereditary endothelial disease, they are often associated with the stromal disease.
Yes, sir. Yes, sir.
And we resort to PK.
Yes, sir. Yes, sir.
What was the age?
13 years, sir.
13
3, yes,
so,
sir.
And it is since birth?
Yes, sir.
Presentation is
Yes,
since
yes,
birth.
sir.
Okay, so since 30-year patient was stroma was edematous, so there are a lot of secondary changes to the stroma, as sir rightly said.
Yes, sir. So
Endothelial
actually there
keratoplasty
was
is,
issue
and
that
second thing is patient is phakic.
Yes, sir.
So again, endothelial keratoplasty is difficult thing to perform. So you can opt for
PK.
PK also.
Yes, sir. Yes, sir.
And better to go for one ASOCT, anti-segment OCT.
Yes, sir.
Did you perform?
Actually, sir, child was having nystagmus and he was not, I mean, even if you see, these are the blurred pictures. I apologize for that, but we tried a lot. That's after that only we could get this kind of pictures. Otherwise, he was very irritable and nystagmus was a main issue with that. Otherwise, ASOCT was in the plan to capture.
So, thank you.
Thank you, ma'am. Thank you,
Last
sir.
call for the presenters who were absent. Dr. Neha Kiran, Dr. Niranj, okay, right. Dr. Nikita Chaudhary and Dr. Sarkar. No. Okay, so we wind up this session, and thanks to chairpersons and all the presenters for being on time and for being so supportive. Thank you so much.